Welcome everyone in our today's demo session. Let's begin by reflecting on something we often take for granted. Every breath we take, the respiratory system is our lifeline, delivering oxygen to every cell and removing carbon dioxide, a vital balance that keeps us alive and functioning. Without it, no organ can sustain its work for long. In this class, first we will explore the physiology of the respiratory system, means exploring how air enters into our body, how gas exchange occurs at the alveolar level, and how oxygen is transported to different tissues. Then we will dive into the pathophysiology, examining what happens when this delicate process is disrupted, such as in asthma, COPD, or infections, along with the therapeutic options along with different therapeutic options and mechanistic rationale for their use. In this session, we will dive into only few of the topics for your better understanding, so that you can opt the answers once again, which you opted in the quiz session, and understand how this demo class has contributed in your learning journey, which has started just now. So let's start our learning journey. Let's walk through the human respiratory system, our body's gateway to oxygen and energy. Air enters through the nose and paranasal sinuses, where it gets filtered, humidified, and warmed. It then travels down the pharynx and larynx before reaching the trachea. Trachea then splits into the right and left main or primary bronchi, supplying right and left lungs. Each lung is further divided into lobes. The right lung has 3 lobes and the left lung has 2, shaped around the cardiac notch. Similarly, the primary bronchi divide into secondary bronchi or the lobar bronchi that serve the lung lobes. The bronchi then further split into bronchioles, starting from conducting bronchioles, then terminal bronchioles, and finally into respiratory bronchioles. Deep in the lungs, respiratory bronchioles lead to alveolar ducts and alveolar sacs, where gas exchange occurs. The diaphragm below drives ventilation, contracting to draw air in. Let's break down the respiratory system into two key zones, the upper and the lower tract. The upper tract includes the nose, nasal cavity, pharynx, and the lung and the larynx. These structures, as I have already mentioned, warm, filter, and humidify incoming air. The lower tract comprises trachea, bronchi, forming tracheobronchial tree, bronchioles, and the alveoli. Originating from the segmental bronchi, the bronchioles have 3 further divisions, as I mentioned. Further, the segmental bronchi, first the segmental bronchi is split into conducting bronchiole, and which leads to terminal bronchiole. Each terminal bronchiole is split into 2 to 3 respiratory bronchioles, as you see over here. Two to three respiratory bronchioles. Each respiratory bronchiole further splits into 2 to 11 alveolar ducts, and at the end of alveolar duct lie 5 to 6 alveolar sacs. Each sac contains 20 to 30 alveoli. Let's zoom into the final and most critical zone of the respiratory system, the alveoli. These tiny, thin-walled air sacs are the ultimate destination for inhaled air and the primary site for gas exchange, surrounded by a dense network of pulmonary capillaries for gas exchange. The alveoli provides an enormous surface area, about 50 to 70 square meter in total, roughly the size of a tennis court. This vast area, combined with an extremely thin blood-gas barrier, allows for rapid and efficient gas exchange. The alveolar walls are lined with epithelium, while the capillaries are lined with endothelium, separated by the interstitium, a delicate tissue layer that facilitates diffusion. Here, you can see that. Also important are the pores of Cohen. Here they are. These are the tiny openings between adjacent alveoli that help equalize pressure and allow collateral ventilation. Now let's take a closer look at the pulmonary acinus, the smallest functional unit of the lungs where gas exchange and secretion occurs. As I mentioned, it is a unit, means certain smaller microscopic parts would involve in it. The term acinus comes from Latin language, means the berry. We are well known about the raspberry. The picture is shown over here. In the lungs, the acinus begins at the terminal bronchiole and includes all the branching structures that follow. It includes the respiratory bronchioles, alveolar ducts and alveolar sacs, housing approximately 10,000 alveoli per acinus. This region is contained within a secondary larger pulmonary lobule and is composed of specialized epithelial cells including type 1 and type 2 pneumocytes. Type 1 cells form the ultra-thin air-blood barrier, allowing oxygen and carbon dioxide to diffuse efficiently and quite easily. Type 2 cells secrete surfactant. Most importantly, these are lesser in number, fewer in number, these type 2 cells, but they secrete important thing, that is the surfactant, a substance that reduces surface tension and prevents alveolar collapse during exhalation. Gas exchange in the lungs is driven by differences in partial pressures. In the alveoli, oxygen and carbon dioxide move by simple diffusion. That is, they move from the area of higher pressure to the area of low pressure. In the alveoli, oxygen has a higher pressure, that is 104 millimeter of Hg. Then in the arriving deoxygenated blood from the heart, and it has a partial oxygen has a partial pressure of 40 millimeter Hg. So it diffuses into the blood. Meanwhile, carbon dioxide with a higher pressure in the blood, 45 mm Hg, moves into the alveoli to be exhaled. In tissues, the process reverses altogether. Oxygen diffuses from blood to the cells and carbon dioxide from cells to the blood. A key player here is the enzyme carbonic anhydrase in the red blood cells, which converts carbonic acid into carbon dioxide and water in the alveoli and facilitates its removal. Let us walk through how carbon dioxide is transported in the blood and how it's exchanged at both tissue and alveolar levels. Carbon dioxide is a waste product of cellular metabolism and it travels in three main forms. About 7% is dissolved directly in plasma, 23% bound to hemoglobin forming carbaminohemoglobin, and the majority, around 70%, is carried as bicarbonate ions. At the tissue level, carbon dioxide diffuses from cells into RBCs, where the enzyme carbonic anhydrase catalyzes the reaction of carbon dioxide and water, which gets converted to H2CO3, which dissociates into hydrogen and bicarbonate ions abruptly due to slightly lower acidic pH of RBCs than the blood. The bicarbonate ion then diffuses out into plasma, and to maintain electrical neutrality, chloride ions move into the RBCs. This process is called the chloride shift. As the blood reaches the lungs, the process reverses altogether. In the primary pulmonary capillaries, bicarbonate re-enters the RBCs. These bicarbonate ions were traveling in the blood. Now at the pulmonary capillaries level, they re-enter the RBCs and chloride exits. Carbonic anhydrase again catalyzes, but now the reverse reaction. Bicarbonate and hydrogen ion combine to form H2CO3, which dissociates into carbon dioxide and water. The newly formed carbon dioxide diffuses across the alveolar membrane into the alveolus to be exhaled out. Let's explore the concept of ventilation-perfusion ratio, which is called VQ ratio. It is the key for gas exchange. Ventilation is the air. Ventilation means the air reaching the alveoli. Perfusion is blood flow within the pulmonary capillaries. Ideally, the ratio is approximately 0.8, meaning 4 liters of air and 5 liters of blood per minute are interacting. In the normal case, air enters the alveolus, blood flows through the capillary, and exchange is efficient, means ideal VQ match, and 0.8 VQ ratio is maintained. Low VQ, also called shunt perfusion, happens when blood flows but ventilation is impaired due to something happened in the airway or the lungs. It can happen, for example, as in the case of airway obstruction and pneumonia. Oxygen cannot enter, so the blood remains deoxygenated. Blood is there, but oxygenation doesn't happen because of problem in the airways or the lungs. This is wasted perfusion causing hypoxemia. High VQ, also called dead space ventilation, happens when ventilation occurs but perfusion is absent. Now in the pulmonary capillaries, blood circulation is less due to For example, pulmonary embolism, severe hypotension, cardiogenic shock. Air reaches alveoli, but no blood is available for exchange. This is wasted ventilation. The formula is simple, that is VPI is equal to V over Q. VA is alveolar ventilation and Q is the blood flow. Understanding VQ mismatches is crucial in diagnosing and managing respiratory conditions, whether the problem is blocked airways or blocked vessels. Any imbalance disrupts oxygen delivery and compromises tissue functions. Alveoli are the microscopic sites of respiration lined by two types of cells. Type 1 pneumocytes cover almost 95% of the surface. They are thin squamous cells that minimize diffusion distance, allowing rapid gas exchange, while type 2 pneumocytes, though they are fewer in number, secrete important thing which is pulmonary surfactant, which lowers surface tension, prevents collapse during exhalation and ensures its smooth expansion. Surrounding alveoli is a dense capillary network forming the blood-air barrier, where oxygen enters blood and carbon dioxide exits. The interstitial space is minimal, enabling fast diffusion. Then come the alveolar macrophages, which are also called the dust cells, patrol the alveolar space, clearing debris and pathogens. Alveoli are interconnected by pores of Kohn, as I explained earlier, which equalize pressure and provide collateral ventilation if an airway is blocked, if the airway is blocked. Elastic fibers in alveolar walls also stretch and require maintaining rhythm and efficiency. Together, these cells and structures create a finely tuned system for gas exchange, immune defense, and mechanical function. Let's talk about alveolar surfactant, a critical substance that keeps our lungs functioning smoothly. It is synthesized and secreted by type 2 pneumocytes and is stored in laminar bodies. Once released, it forms a thin film over the alveolar surface. Surfactant is composed of 90% lipids, mainly DPPC, and 10% proteins, including surfactant proteins called SPA to D, which help spread and stabilize the surfactant. Its primary role is to reduce surface tension by intercalating between water molecules, preventing alveolar collapse during exhalation. This is especially vital for smaller alveoli, which are more prone to collapse. Without surfactants, breathing would require much more effort and gas exchange would be compromised. It's a microscopic shield that makes every breath possible. Another important topic is the cyclooxygenase and lipoxygenase pathways. Let's dive into two critical branches of arachidonic acid metabolism, cyclooxygenase or COX and lipoxygenase or LOX pathways, released from membrane phospholipids by phospholipase A2. Arachidonic acid is converted into potent mediators. COX pathway, including COX1 and COX2, produces prostaglandins and thromboxanes, which regulate inflammation, pain, fever, platelet aggregation, and airway tone, while the LOX pathway generates leukotrienes and lipoxins. Leukotrienes cause bronchoconstriction and drive asthma and allergy, while lipoxins help resolve inflammation. These mediators shape airway reactivity, inflammation, and repair. This regulation contributes to asthma, COPD, and aspirin exacerbated respiratory disease. Targeting these pathways with bronchodilators, steroids, leukotriene inhibitors, and biologics provide therapeutic control. In the upcoming slides, some of the pathologies are discussed, and we will cover only few topics under a disease. While in our detailed session in our regular classes, we do cover introduction of disease types and hereditary parameters, etiology and causes, pathogenesis, signs and symptoms, screening and diagnosis, different lab tests, and at the last, a glimpse of different therapeutic modalities. Here we will cover only some of these topics per disease. First among them are the obstructive and restrictive lung diseases, COPD or CRPD. Obstructive lung diseases involve blocking of airflow out of the lungs. Airways are narrowed or inflamed, making exhalation slow and incomplete, leading to air trapping and increased residual volume. Conditions include COPD, including chronic bronchitis and emphysema, asthma, bronchiectasis, and cystic fibrosis, while the symptoms include wheezing, chronic cough, and shortness of breath. On the other hand, restrictive lung diseases limit lung expansion due to stiffness, scarring, or external restriction, reducing lung volumes and compliance. Intrinsic causes include pulmonary fibrosis for CRPDs, sarcoidosis, interstitial lung diseases, while the extrinsic causes include chest wall deformities because of maybe scoliosis and kyphosis. Neuromuscular disorders like ALS and obesity hypoventilation syndrome. While the symptoms include rapid breathing, dry cough, and breathlessness. So, in summary, obstructive lung diseases block airflow out and restrictive lung diseases limit airflow in. Let's compare the two in the table by focusing on their mechanical and diagnostic differences. Now, let's look at the table. In COPD, airflow is obstructed due to narrowed or inflamed airways. This makes exhalation difficult and leading to air trapping. I repeat, this makes exhalation difficult and leads to air trapping. Compliance is increased because the lungs lose their elastic recoil like overstretched balloons. In contrast, CRPD involves stiff lungs or chest wall restrictions, making inhalation difficult. Here, compliance is decreased due to fibrosis, scarring, or external compression. In COPD, the FEV1 FVC, forced vital capacity ratio, drops below 70%. FVC may be normal or slightly reduced, but residual volume increases due to air trapping. In CRPD, both FEV1 and FVC are reduced, but the ratio remains normal or even elevated. Total lung capacity is low, reflecting the inability to fully expand the lungs. Treatment strategies also differ. COPD management focuses on bronchodilators, inhaled corticosteroids, and smoking cessation, while the CRPD treatments target the underlying cause, whether it's inflammation, neuromuscular dysfunction, or structural deformity, and may include immunosuppressants, oxygen therapy, and pulmonary rehab. Now, the another disease or pathology is ARDS, termed as acute respiratory distress syndrome. Here we will focus main on the NRDS, neonatal respiratory distress syndrome. ARDS is a rapid life-threatening respiratory failure where inflammation causes fluid leakage into alveoli, blocking oxygen transfer. This leads to severe hypoxemia, poor compliance, and ventilation perfusion mismatch. Infant respiratory distress syndrome, NRDS, often in premature newborns, results from surfactant deficiency. Without surfactant, alveoli collapse, causing hyaline membrane disease and severe breathing difficulty. NRDS features alveolar collapse, impaired compliance, ventilation, perfusion mismatch, hypoxemia, and histologic hyaline membranes, hallmark of the NRDS, hyaline membrane diseases. This is distinct from adult RDS, which is inflammatory diffuse alveolar damage. Now let's see etiology and causes. Neonatal ARDS or respiratory distress syndrome is primarily caused by surfactant deficiency. It is caused by surfactant deficiency, especially in premature infants. Surfactant is produced by type 2 pneumocytes and helps keep alveoli open. Without it, the lung collapses, making breathing extremely difficult. Secondary contributors may also include perinatal asphyxia, maternal diabetes, etc., which delays surfactant production, and elective caesarean deliveries without labor, which bypass the hormonal triggers for lung maturation. Other risk factors include multiple gestation, male sex, and cold stress at birth. There are certain rarely genetic mutations in surfactant-related genes which mimic ARDS even in late preterm or full-term infants. These cases may be resistant to standard treatments like surfactant replacement and steroids and often warrant genetic evaluation. Now coming to the NRDS pathogenesis, which starts with surfactant deficiency in premature lungs, increasing alveolar surface tension, causing widespread atelectasis, means alveolar collapse, and decreased lung compliance, demanding more work to breathe, leading to hypoxemia, inflammation, fluid leakage, or edema, and potential respiratory failure if untreated, with stages involving exudation, proliferation, and fibrosis. Here are the steps in detail. Surfactant deficiency. Immature type 2 pneumocytes in premature infants don't produce enough surfactant, a substance crucial for reducing surface tension in alveoli. Increased surface tension and atelectasis. Without enough surfactant, the surface tension in the small airways and alveoli becomes too high, making them prone to collapse, which is called atelectasis. Reduce lung compliance and increase work of breathing. Collapsed alveoli don't participate in gas exchange and the lungs become stiff, means decreased compliance, requiring significantly more pressure and effort, which is called the increased work of breathing to inflate. Hypoxemia and shunting. Blood passes through collapsed atelectic lung areas, but doesn't get oxygenated, creating a right to left shunt, causing low blood oxygen levels, which is also termed as hypoxemia. Inflammatory response and edema. Repeated collapse and reopening damage the delicate respiratory epithelium, triggering an inflammatory cascade leading to increased permeability of the alveolar capillary membrane and fluid leakage, which is also called as pulmonary edema, into the alveoli. Finally, respiratory failure. If untreated, this leads to severe hypoventilation, carbon dioxide retention, respiratory acidosis, muscle fatigue, and ultimately respiratory failure. For the pharmacotherapy, let's begin with antibiotics, which are essential when infection complicates ARDS. Ampicillin sulbactam dose at 50 mg per kg IV every 6 hours combines a penicillin with a beta-lactamase inhibitor. It targets commonly pathogens in cystic or collapsed lung tissues by disrupting cell wall synthesis. Ceftriaxone, given only once daily at 50 to 75 mg per kg IV, is a third generation cephalosporin with excellent lung penetration and broad spectrum coverage for resistant organisms like MRSA. Vancomycin is used at 15 mg per kg IV every 6 to 8 hours. It inhibits peptidoglycan synthesis and is reserved for severe gram-positive infections. Next is azithromycin. A macrolide is dosed at 10 mg per kg orally on day 1, followed by 5 mg per kg daily for 4 days. It covers atypical pathogens and also modulates airway inflammation, especially useful in reactive airway components of ARDS. Moving to anti-inflammatory and airway support, dexamethasone. Dexamethasone, a corticosteroid, is given at 0.25 to 0.5 mg per kg every 6 hours IV or orally. It reduces airway edema and is particularly helpful in compressive lesions or stridor. Salbutamol, or also called albuterol, a short-acting beta-2 agonist or stimulant, is nebulized at 0.15 mg per kg every 20 minutes for up to 3 doses. Then, whenever it is as needed, SOS basis. It relieves bronchospasm and improves airflow. For symptomatic relief, acetaminophen or paracetamol is given 10 to 15 mg per kg every 6 hours, helps manage fever and discomfort during infection or post-infection. A cornerstone of neonatal ARDS management is exogenous surfactant therapy. Agents like biractant are administered intratracheally at 100 mg per kg. They restore alveolar stability and improve gas exchange in surfactant-deficient lungs. Supportive care includes IV fluids and oxygen therapy, titrated to weight and clinical status. These stabilize hemodynamics and oxygenation, especially in acute respiratory distress. Additional agents used in some institutions include caffeine citrate, a methylxanthine stimulant given as a 20 mg per kg loading dose, followed by 5 to 10 mg per kg daily. It enhances respiratory drive and reduces apnea in preterm infants. Inhaled nitric oxide, dose at 5 to 20 ppm, that is parts per million, acts as a pulmonary vasodilator. It is used in cases with pulmonary hypertension to improve oxygenation. Morphine and midazolam provide sedation and analgesia. Morphine at 0.05 to 1.1 mg per kg IV every 2 to 4 hours and midazolam as a bolus followed by infusion. These agents reduce agitation and oxygen demand, facilitating mechanical ventilation. Now comes pneumonia, whether community-acquired pneumonia or nosocomial pneumonia, which is also called as hospital-acquired pneumonia. At its core, pneumonia is an infection of the lung tissue or parenchyma. It causes inflammation in the alveoli and leads to consolidation, meaning the air spaces are filled with fluid and pus. Clinically, this can range from a mild illness in the community to a life-threatening infection acquired in hospitals. The way pneumonia presents and how we manage it depends on three key factors. One, the pathogen spectrum, which organisms are responsible. Two, host factors, the patient's age, comorbidities, and immune status. Three, the care setting, whether the infection was acquired in the community or in the hospital. Now let's break down the types of pneumonia. First is community-acquired pneumonia. This is acquired outside hospitals or long-term care facilities. Common pathogens include Streptococcus pneumoniae, which is most common. Streptococcus pneumoniae, Haemophilus influenzae, and atypicals like Mycoplasma. In hospital-acquired pneumonia, it occurs typically 48 hours or more after administration. I repeat, it occurs 48 hours or more after administration and was not intubated at the time of admission. These cases often involve resistant organisms such as Pseudomonas or MRSA. I repeat, the pathogens most common involve are Pseudomonas aeruginosa and Staph aureus, but MRSA type, methicillin-resistant Staph aureus. Ventilator-associated pneumonia, a subset of HAP, hospital-acquired pneumonia, developing in patients who have been intubated for more than 48 hours. Now let's have a look at the etiology and causes. For the community-acquired pneumonia, the main bacteria are Streptococcus pneumoniae, Haemophilus influenzae. Atypicals include Mycoplasma, Chlamydia pneumoniae, Legionella acquired from water sources, viruses including influenza, respiratory syncytial virus RSV, SARS-CoV-2, occasionally Staph aureus, but they are not common, including MRSA. In hospital-acquired pneumonia and ventilator-associated pneumonia, resistant gram-negatives like Pseudomonas, Klebsiella, Enterobacterales, Staph aureus MRSA, Acinetobacter, often polymicrobial due to hospital environment. There are multiple types of pathogens are present in the hospital environment. Most common pathogens are Pseudomonas and MRSA. The host factors include immunosuppression, aspiration risk, structural lung disease, broadened spectrum of including fungi, non-tuberculous mycobacteria, and certain opportunist bacteria or pathogens. The risk factors include age extremes like in infants and elderly, smoking, COPD, bronchiectasis. Comorbidities include heart disease, diabetes, alcoholism, and malignancy. Immunosuppression, whether due to drug or disease, recent influenza or antibiotics. Aspiration, especially in the neurological impaired patients. Prolonged hospitalization and mechanical ventilation. Now let's see the pathogenesis. Pneumonia results from pathogenic invasion of the lower respiratory tract caused by microaspiration, inhalation, or hematogenous spread. Community-acquired pneumonia often involves Streptococcus pneumoniae or viruses stemming from environmental exposure and weakened immunity. Hospital-acquired pneumonia occurs post-admission 48 hours, more than 48 hours, arises from aspiration of flora colonizing the hospital environment, often featuring drug-resistant bacteria. The two common types, CAP and HAP. In the community-acquired pneumonia, the pathogenesis occurs outside hospital when pathogens overwhelm defenses. The mechanism involves microaspiration of oropharyngeal flora, especially during sleep, inhalation of aerosols like Legionella, and rarely hematogenous spread. The common pathogens are Streptococcus pneumoniae, Haemophilus influenzae, Moxilla catarrhalis, and atypicals including Mycoplasma and Chlamydia. while the viruses, as already explained, include influenza, SARS-CoV-2 and RSV. Host factors include age, smoking, alcohol misuse, chronic lung disease, comorbidities, immunosenescence in elderly weakens lung defenses. As mentioned earlier, the hospital-acquired pneumonia develops 48 hours after admission, often in ICUs. The mechanism include aspiration of colonized oropharyngeal or gastric secretions. Hospitalized patients' oral cavity often colonized by gram-negative cavities like E. coli and Klebsiella and Staph aureus. As far as the risk enhancers are concerned, the intubation in ventilator-associated pneumonia, intubation, impaired consciousness, acid suppression, and poor nutrition. While the pathogens most common are the MRSA and Pseudomonas aeruginosa, and others are enteric, gram-negative bacilli, and Acinetobacter species. Now let's see pharmacotherapy. When treating pneumonia, the choice of antibiotic depends on whether it's community-acquired or hospital-acquired and on the likely pathogens. Let's begin with community-acquired pneumonia. For otherwise healthy outpatients, amoxicillin is often the first choice. It's a beta-lactam antibiotic that inhibits bacterial cell wall synthesis, and at a dose of 1 gram orally given 3 times daily, it reliably covers Streptococcus pneumoniae. If the patient has comorbidities or risk factors, we use amoxicillin clavulanate. The clavulanate component blocks beta-lactamases, extending coverage to organisms like Haemophilus influenzae and Moraxella. For hospitalized patients, ceftriaxone, a third-generation cephalosporin, is given at 1 to 2 gram IV daily. It provides broad gram-positive and gram-negative coverage, especially for pneumococcus. Another option is ampicillin sulbactam, which combines a beta-lactam with a beta-lactamase inhibitor, useful for mixed infections. Now, atypical pathogens like Mycoplasma and Legionella require different coverage. That's where azithromycin, a macrolide, or doxycycline, a tetracycline come in. Azithromycin is dosed at 500 mg once a day, then 250 mg daily for 4 days, while doxycycline is given 100 mg twice daily. Both inhibit protein synthesis and target atypicals. Alternatively, levofloxacin, a respiratory fluoroquinolone, can be used at 750 mg daily. It covers both typical and atypical organisms and is especially useful in resistant pneumococcal infections. For hospital-acquired pneumonia and ventilator-associated pneumonia, the pathogen spectrum shifts towards resistant gram-negatives and MRSA. Piperacin, tazobactam are the drug of choice at 4.5 gram IV every 6 to 8 hours. Is a broad beta-lactam with activity against Pseudomonas and anaerobes. Now comes cefepime or cefepime, a 4th-generation cephalosporin at 2 gram IV every 8 hours, also covers Pseudomonas and is stable against many beta-lactamases. In cases with multiple resistant, carbapenems like meropenem may be required. For MRSA coverage, vancomycin or linezolid are added. Here I would like to mention that linezolid is a protein synthesis inhibitor which can be used as alternative to vancomycin for MRSA pneumonia. Now, the last disease or pathology that we will cover in our demo session is asthma. Now, coming to asthma, asthma is a chronic lung disease where airways become inflamed, narrowed, and filled with mucus, making breathing difficult. Symptoms including coughing, wheezing, chest tightness, and shortness of breath. The triggers vary, and the common ones are allergens, smoke, exercise, and cold air. On slides, we can see the normal airways show relaxed muscles and free airflow, while in asthma, walls are thickened, muscles tighten, and mucus build up. During attacks, these changes trap air in alveoli, worsening distress. Asthma is heterogeneous. Some patients have mild, intermittent symptoms, while others suffer severe treatment-resistant disease with risk of permanent airflow limitation. Now let's visit etiology and causes. Asthma is multifactorial, arising from genetic susceptibility and environmental exposures. Atopy, allergic sensitization, or early life viral infections increase risk, while tobacco, smoke, pollution, and occupational sensitizers also contribute. The triggers include allergens like dust mites, pollens, animal dander, molds, viral infections like rhinovirus, exercise, cold air, smoke, and strong fumes. Other aggravators include NSAIDs in aspirin exacerbated disease, GERD, and emotional stress. Now come to asthma pathogenesis, which involves the complex interplay of genetic and environment, leading to chronic airway inflammation, hyperresponsiveness, and reversible airflow obstruction, characterized by smooth muscle contraction, mucus plugging, and airway remodeling, which is the thickening of the walls. Initial exposure to triggers like allergens, viruses, irritants activates immune cells, which include T cells, mast cells, and eosinophils, releasing inflammatory mediators like histamine, causing immediate bronchoconstriction, and later recruiting more cells, perpetuating inflammation and airway narrowing, making breathing difficult. Let's dive into the steps of pathogenesis. First one is the sensitization or the initial exposure. First time exposure of the allergens, which are inhaled as pollens or dust mites. The dendritic cells present them to T helper 2 cells, which release cytokines, especially interleukin 4 and interleukin 13. The B cells are also signaled to produce IgE, immunoglobulin E type, which binds to mast cells, hence priming them for later stages. In the early phase that happens minutes after re-exposure, allergens bind to IgE on sensitized mast cells, causing them to degranulate and release mediators like histamine, leukotrienes, prostaglandins, which cause immediate effects like bronchoconstriction, mucus secretion, and airway edema. In the late phase, which occurs hours after exposure, recruitment of eosinophils, neutrophils, T cells happen to lungs, which release cause sustained and persistent with bronchospasm. Airway becomes hyperresponsive to the triggers. In the chronic asthma manifestations, chronic changes occur, that is airway remodeling. Repeated inflammation causes irreversible structural changes like subepithelial fibrosis, smooth muscle hypertrophy, mucous gland hyperplasia, and most importantly, angiogenesis, which is increased blood vessel formation. Now coming to the pharmacotherapy of asthma. Asthma treatment relies on a wide spectrum of drugs, each targeting a different mechanism. Short-acting beta-2 stimulants or agonists like salbutamol provide rapid relief by relaxing airway muscles, making them the go-to rescue inhalers. For long-term control, inhaled corticosteroids such as beclomethasone reduce inflammation, while combination therapies like budesonide and formoterol deliver both anti-inflammatory action and sustained bronchodilation. When symptoms are more persistent, long-acting beta-2 agonists like formoterol, always paired with corticosteroids, help maintain control. Add-on therapies such as tiotropium, a muscarinic antagonist, further open the airways in severe cases. Meanwhile, a cornerstone, montelukast, a leukotriene receptor antagonist, can also be given, which blocks chemical signals that drive inflammation and mucus production. For acute exacerbation, systemic corticosteroids like oral prednisolone provide powerful suppression of airway inflammation. In patients with allergic asthma, biologics such as omalizumab target IgE, prevent mast cell activation. For eosinophil asthma, drugs like mepolizumab and benralizumab blocks interleukin 5 pathways, reducing eosinophil activity. Dupilumab expands this by blocking IL-4 and IL-5, interleukin 4 and interleukin 13, signaling, while tezepelumab acts even further upstream, inhibiting TSLP to dampen the entire inflammatory cascade. Finally, azithromycin, though an antibiotic, is sometimes used prophylactically for its immunotherapy effects, reducing exacerbation frequency.